Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you, Dr. Reem, for a nice introduction. Thank you for the invite. It's my pleasure today to talk about acute leukemia of ambiguous lineage. And during this talk, I'll be covering the diagnostic update, the genetic aspect, and a few challenging cases, diagnostic tips and pitfalls. So acute leukemia of ambiguous lineage are those leukemias that show evidence of commitment to more than one lineage or fail to show the evidence of commitment to myeloid T or B myeloid lineage. It consists of mixed phenotype leukemia or MPAL and acute undifferentiated leukemia or AUL. MPAL represent less than 3% of acute leukemia, and the outcome generally is poor based on few retrospective studies, and therefore it's considered high-risk disease. It can be B myeloid, which compose the vast majority of cases, or T myeloid, and rarely TB or tri-lineage leukemia. Acute undifferentiated leukemia is very rare, and the blasts usually co-express immaturity marker, and they lack the specific lineage antigen, but they may express a single myeloid or a lymphoid-associated antigen. And it is very important to exclude uncommon hematobiotic neoplasms such as BBDCN, megakaryoblast, and basophil leukemia. So the recent classification of WHO included two broad categories of MPAL. The first is MPAL with defining genetic abnormalities, including the previously known MPAL with BCR-ABL and KMT2 rearrangement. And they have newly added two new sub-entities, MPAL with ZNF384 rearrangement and BCL11B. The second category is MPAL immunophenotypically defined and includes B myeloid, T myeloid, rare, and not otherwise specified category. So as you are aware, the first diagnostic scoring system was proposed by European Group for Immunologic Classification of Leukemia, abbreviated as EAGLE classification, and it consists of a large list of markers, and each marker assigned weighted score depending on how strongly that marker associated with the lineage. For example, CD79A considered a strong marker, and that's why for B lineage, and that's why given score 2. So biphenotypic leukemia was diagnosed if the score is more than 2 for more than one lineage. And it's worth mentioning that the positivity for the antigen in that scoring system was defined as more than 10%. That was modified by the WHO classification. And as you can see, the scoring system was eliminated, and the long list of markers was shortened as well to include only the specific marker and the frequently associated marker. So for B lineage, assignment, we need strong CD19 and more than one B lineage associated marker. If the CD19 is weak, then you need more than 2 B lineage associated marker. For T cell lineage, you need surface and cytoplasmic CD3. For myeloid lineage, you need MPO, or more than 2 monocytic differentiation marker, including NSA, CD11C, CD14, 64, and lysozyme. And there was no minimum positivity threshold for any of these markers, and also the antigen intensity expression was not objectively defined. So even with the WHO stringent criteria for diagnosis of ALAL, acute leukemia of ambiguous lineage still pose a diagnostic challenge for most of the pathologists, as we have no consensus yet about the minimum threshold for percent-positive antigen cells in biphenotypic leukemia, especially for the markers that show nonspecific and autofluorescence, such as MBO staining. Also, in the presence of minor cell population fulfilling the criteria of WHO for lineage assignment in the setting of PLL. Also, there was no objective definition of antigen intensity. Also, the discrepancy between the methods that used within a lab for assessing antigen expression, such as immunohistochemistry and flow cytometry, was not addressed in the previous classification. So the most updated WHO classification has addressed some of these issues related to antigen expression intensity as they define, the strong expression as more than 50% or more than 1.5 log of the normal cell population above the background. So looking at the MBO dot plot here, the blast is in the dark green. So by plotting an imaginary line between the true negative population and the true positive population for MBO, you can see that the blast is reaching or exceeding the mid-half of that line and qualified for strong positive expression. So how about BLL with isolated MBO? We know that MBO is a specific marker for myeloid lineage. However, it has been reported to be positive in a small subset of BLL. And that terminology was used by WHO previous classification and defined as homogeneous blast population of typical BLL immunophenotype with weak expression of MBO. However, the expression of MBO was not properly defined, and the clinical significance was or is still controversial. So this is a recent abstract by Brentwood. They looked at 100 patients with MPAL. The majority are of B myeloid lineage. And they described different pattern of MBO expression. And he used the intensity of more than 50% of normal population and above background as sufficient criteria to assign lineage in MPAL. And using that threshold, interestingly, he found that more than half of the cases he reviewed that was classified in the previous classification as B myeloid MPAL are actually B myeloid MPAL with isolated MBO expression. That was defined by him as a weak aberrant expression of MBO, which is less than 50% of the true positive population and above the background. Okay. So this is a recent study by Euroflow. They looked at more than 1,000 of acute leukemia allot analysis. They tried to assess the diagnostic performance of MBO using percent-positive population compared to mean fluorescence intensity or median fluorescence intensity, which is representative of antigen intensity expression. And they find that MBO positivity of more than 20% of acute leukemia exceeding the lymphocyte threshold are actually performing greatly compared to the median fluorescence intensity or mean fluorescence intensity to differentiate the MBO positive versus MBO negative leukemias. As you can see here in that graph, we have here the MBO positive leukemia and MBO negative leukemia, the MBO percent positive cutoff of more than 60 able to distinguish these two groups compared to the median fluorescence intensity and mean fluorescence intensity. And actually by using that 20% positivity cutoff, they find that 98% of ALL are actually MBO negative. So how about the genetic aspect of the disease? And again, this is a nice work by Alexander et al. They looked at more than 100 childhood ALL, and they did a comprehensive genomic analysis, including whole genome sequencing, transcriptome, and WIS as well. And they find that most of MPAL cases harbor mutually exclusive mutation of WT1, ETV6, RUNX1, and CYP-A as well. And we know that these mutations are shared by ALL as well as AML. And interestingly, they find that ALL overlap with other defined leukemias, not only in the immunophenotype level, but also at the genetic level. So as you can see here, they find that B myeloid MPAL share ZNF384 rearrangement as well as KMT2A rearrangement with BLL, and also T myeloid MPAL share BCL11B and KMT2A and FLT3 mutation with ETB, ALL, and MLL, and AML, sorry. So how about MPAL with ZNF384 rearrangement? It represents about half of B myeloid MPAL and 10% of BLL. They have different fusion partner that dictate different disease phenotype. They have a characteristic immunophenotype similar to KMT2A gene rearrangement, which is weak or negative CD10 and aberrant expression of CD13 and 33. Interestingly, they have higher expression of a FLT3 mutation, and this may play a role in the management of these patients. Also, ZNF384 rearranged BLL are prone to lineage switch post-chemotherapy. So how about lineage switch? It can occur at relapse or even during therapy. The most common is lymphoid to myeloid, or rarely the opposite, or even to ambiguous lineage. It was reported frequently post-targeted therapy, CD19 CAR T cell or blinatumomab. And this is one of the largest study looking at more than 160 BLL treated with CAR T therapy, and 7% of them demonstrated lineage switch, and more than 2/3 of them harbor KMT2 rearrangement. Lineage switch can be due to clonal evolution, transcriptional factor reprogramming, or subclonal selection secondary to therapy. It has been frequently reported with KMT2 rearrangement and ZNF384 rearranged leukemia. And now we will go through a few challenging cases. The first case is for a 16-year-old male, KMT2 rearranged BLL, and he was transplanted. This is his day 170 post-allogenic stem cell transplant. And looking at the dot plot of forward side scatter versus side scatter, we know that forward side scatter gives an indication of cell size, while side scatter is for cellular granularity. So you can see that we have uniform, homogeneous blast population with a small to medium size and low side scatter. They are CD45 dim. They co-express CD19, but they lack CD10, and they have partial expression of cytoplasmic 79A. They have dim TDT expression, 34 positivity, and they lack CD33 myeloid marker, monocytic markers such as 64 and 11C, and also MBO expression. And these blast population also they show aberrant CD15 expression. The bone marrow morphology show medium-sized blast, and the flow was consistent with BLL with aberrant CD15. the FISH studies came back to be positive for KMT2A rearrangement. So the final diagnosis was BLL with KMT2 rearrangement in relapse. This patient received flag induction, and 2 weeks was flag induction. He had persistent blast, and that was his bone marrow was repeated. And as you can see here, in the flow, in forward side scatter and side scatter, we have two blast population. The first one has small forward side scatter and small side scatter. The second population has higher forward side scatter and lower side scatter, indicating small and large population. Forward side scatter, CD45 with side scatter also indicated presence of two population. The red population has lower side scatter. The green has higher side scatter. If we focus on the red, they co-express CD19, but they lack CD10, partial expression of cytoplasmic 79A. Also, they co-express CD22. And looking at that plot, we can see that the blast has bifurcation, and that pattern has been described frequently with BLL as that population, they co-express CD34, but they lack the myeloid marker, while the gray population here, they show CD33. And looking at the monocytic marker, 64 and 11C, it was also expressed. CD13 was positive as well. Also, if you pay attention to the MPO, we have about 18% of blasts co-expressing MPO. So the cytogenetic also came back to show translocation for 11 with an additional clone. So the final diagnosis, was B-myeloid MPAL with a KMT2 rearrangement, secondary to lineage switch from BLL with KMT2 rearrangement during the second induction. And this is really important because the lineage switch happened within 2 weeks from previous relapse. And I think this has a huge implication because currently we are using Euroflow. Most of us use Euroflow, and we focus usually at the diagnostic panel. So if at that time we didn't use the Euroflow, so we run the whole panel, including AML and BLL. So it's very important to do full panel for at least for KMT2 rearrangement to avoid missing lineage switch. Okay. So the second case, it was for 18-year-old male with history of TLL, relapsed, and he is now cytopenic, and the flow cytometry post-induction in another center showed query TB MPAL or lineage switch. So we run the flow, and you can see again that we excluded the doublets, focusing on the singlet, looking at the forward side scatter and side scatter. We have the red population here representing the blast, homogeneous, uniform with variable forward side scatter from the small to large. They are dim in CD45. They co-express cytoplasmic CD3, and it's really strong compared to the normal control. In the blue here, we have T lymphocytes. Also, they co-express CD13, but also, interestingly, they show CD19 expression, similar to the referral center. Also, CD79A was partially expressed. However, this is a diagnostic pitfall. CD79A cannot be used in the setting of TLL as a diagnostic or a lineage assignment marker for TLL. And the caveat for that it is frequently seen with TLL. Also, these populations are bright positive for CD7. They lack CD10 and CD22 as a B associated marker. And they show weak CD5. They co-express myeloid antigen 13 and 33. They lack 117, and they are negative for 1A, TDT, and CD20. So what is the diagnosis? Also, we send for immunohistochemistry for BAX5, and it came back to be negative as another confirmatory test that there's no B-lineage assignment criteria here. So the final diagnosis was early T-cell precursor TALL or ATB with aberrant CD19. And this is really important as we know that this subtype of TLL, usually they have poor response to the induction or positive MRD.
You have 5 minutes, Doctor.
The last slide. So for the diagnostic tips and pitfall, in relation to the assay and in relation to the flow cytometry assay, it's very important to have the test optimized in relation to compensation, BMT voltage optimization. Also, the flow lab must follow a quality assurance system on daily basis. It's very important to have a good knowledge about the performance of antibody used, as we have different clone and different conjugate, and each clone react differently to and gives you different signal of the antibody. For the analysis, it's very important to use forward side scatter with side scatter to identify the different size population. Also, it's very important to show the normal counterpart population to be able to visualize the antigen expression, intensity. Also, the most important thing, as we demonstrated in the previous cases, that MPAL show antigen expression heterogeneity and coordinated antigen expression pattern compared to the already defined leukemia, such as ALL or AML. Also, it's very important to interpret the result cautiously with the cytogenetic and molecular results, knowing that some of well-defined entity of leukemia can show lineage infidelity, such as core-binding leukemia, AML with MRC, and CML in blast phase, or Philadelphia-like leukemia, and these are well-defined entity and should not be considered as MPAL. Lineage switch can be a diagnostic pitfall as well, as we show in our cases, and it can be missed if the focus is only on the diagnostic panel, especially with KMT2 rearrangement cases. Okay, thank you very much.